Hello, everyone. Welcome to Leading Rural Healthcare, the podcast where we talk with leaders shaping the future of healthcare in rural communities. I'm your host, Brendan Hurley, and I'm blessed. Joining me today is Darinda Dick, President and CEO of Western Missouri Medical Center here in Warrensburg, Missouri. WMMC is an independent county-owned health system, which will be the first on this podcast, serving Johnson County and the surrounding region. Under Darinda's leadership, the hospital has expanded access to care, strengthened its physician ranks, and achieved national recognition for quality. Darinda began her career as a nurse, which instilled a deep commitment to patient and family-centered care and a passion for building strong collaborative relationships. This experience served her well as a chief nursing officer and now as the hospital's CEO. Her leadership has helped WMMC advance time-critical care programs like stroke, STEMI, and trauma while building a culture focused on compassion, collaboration, and evidence-based care. You've got a lot going for you, Darinda. Welcome to Leading Rural Healthcare. I'm glad to have you on the show.
Thanks for having me.
So, as I'd like to start, just tell us about yourself. Why'd you choose healthcare, and really tell us a little bit about Western Missouri Medical Center.
Like so many people, I lucked into healthcare. My mom is a nurse. I have lots of nurses in my family, and so I became a nurse. Went to UCM here in Warrensburg and became a nurse 30 years ago. So it's been a minute.
Mhm.
And what I really loved about being a nurse and what ultimately shaped that decision was really just my love to talk to people. So
Yeah.
I'm a talker. I like to connect with people. I love working with patients and their families. And so I was pleasantly surprised that being a nurse matched those loves of mine. So I became a nurse 30 years ago and worked the bedside for about the first 10 years of my career. So
Yeah. So you've jumped around a bit. You started your career as a nurse and then eventually became CEO. And if I recall, I had the opportunity to see you on a panel at MHA's convention talking about your days as a night nurse and kind of how that impacted your leadership. But share for our audience, how did those early bedside experiences shape the way you feel like you lead today, or give us some examples.
well, the workforce has changed a lot, but I do reference those days in my mind a lot. And in case people don't know this, your night shift nurses are already CEOs. So they are already
Wow. Yeah.
um, planning everything you need to be doing, criticizing what you're doing.
Yeah.
It's its own independent place at night here at any hospital. So it's a fun environment to work in. So yeah, I was a night nurse really for 12 years. I worked nights exclusively, loved being on nights. And by the end of that time, I moved into a manager role, and really that's when I started noticing that if there was something broke, I wanted to be the one that came up with how we fix it. And when you're an early leader, particularly in nursing, you're just trying to fix things that are for like the work life of a
Yep.
nurse. So you're like, it's 50 steps to the Pyxis. Let's reduce that to 25 steps. Like you're really worried about nurse satisfaction, and that's okay. And I recognize that in young leaders, like that's where they're at in their development stage, is they're just trying to make it a better place to work for the clinicians. And I remember thinking, probably a few years into my first manager job, my chief nurse officer was leading a meeting with all of us, and she was like, that is a patient safety issue. And she kept saying patient safety. And as many know, that can be kind of a buzz phrase. But I
Yeah.
remember thinking inside, when am I going to care about patient safety? I literally thought that, like, when is that going to roll off my tongue? But it does, for whatever reason, it happens. And so I think there is a progression in leadership where you start thinking a little bit higher, a little bit broader,
Hmm.
and it's not only that you're still thinking about what that night shift nurse might feel about what you're doing. But I'm not the one responsible for trying to make sure she's got the
Right.
tools that she needs right every day and the steps she takes to the Pyxis. That's what my younger leaders and my frontline leaders are there for, and they love to do. And so, but still understanding what they might perceive. I mean, I constantly I'm thinking about like what would I have thought of that? What do I think of that? I mean, even though I'm the CEO, I seem to still have the brain of an employee at times where I'm thinking
Yeah.
like that would not feel good. I would not like that. So even when I have to make tough decisions, I'm trying to think of how to communicate that to help either explain it, soften the blow, offset, mitigate. And so that's just something I think I learned those soft skills from really that frontline leadership as a nurse.
Yeah. Well, I mean, and you haven't explicitly stated this, but I mean, being a night nurse, it's not as if there's no oversight, right? I mean, there's administrators on call, you still have your managers, but do you feel like that gives you number one, a sense of autonomy, but number two, hey, we just got to figure it out, right? I mean, it's us, and it happens or doesn't on our watch, right? Just as it would, I guess, with any shift. But I'd like to think there's probably a spotlight on those working those late hours, right?
I think nurses in general, I love, that's actually one of my favorite jokes is while you're in incident command trying to figure out how to get water to the part of the hospital that's water got turned off, the nurses have already figured it out. Like they're not waiting on administration, so like this literally happened to me at one of my jobs. I was in incident command and they were like all these administrators, and I wasn't quite an administrator yet, and they were like thinking of how to get water to the rehab department and how we were going to flush toilets. And I went over there and they had already gotten buckets, went and got water from some other place. They were flushing toilets. They had
Yep.
gotten water brought up from nutrition services. Like they're not waiting for us to fix those little things because they know how to take care of patients.
Yeah.
That's what their desire, their love, their passion is for. And so I think that it's funny that we think we have to fix every little thing, and that's really not how nurses think. And I think particularly at night, you're used to not having and when I was a young nurse, I mean, this was 30 years ago, we didn't see managers at night,
Yeah.
and we were fine with that. We were
I'm sure. I'm
we
sure
were
it has its
good.
benefits.
We were good.
Yeah.
And so if we did see an administrator, it was a really special occasion. So we were kind of excited, like, oh, hey, let's meet you. But there's some changes. There's cultural changes and in the workforce today, and sometimes in different organizations where people are like, I never see my manager. And so inside, I always kind of joke like, I never wanted to.
Yeah.
But some people do like that validation.
Yeah.
And so you do have to like gauge what your staff need. And sometimes your tenure there can change the needs and those kinds of things.
Yeah, we hear that a lot. I mean, I hear that a lot, not just in healthcare, but everywhere. The culture, not maybe the culture is not the right word, but the workforce is definitely different. And that autonomy, that I'm going to do it myself, I'm going to figure it out. It's not that it's not there, but you've alluded to and reading between the lines. I mean, it's maybe a little rarer to find. And so I'm kind of curious. I mean, in that role, and then I'll move on to something else. But is it innate, right, for those in nursing to be that way? Like, is there a chicken egg approach, meaning they get hired into that role a lot of times, or do you, I would imagine, learn that you have to just, you can be in crisis mode and you need to be the one to take accountability and handle that situation, because as you've mentioned, by the time you need to do something, your manager is already just finding out or just aware.
Yeah, I don't want to be insensitive to the trials and tribulations of bedside frontline
Yeah.
nurses because, sometimes they are put in really bad situations. And I'm not saying that this is at my hospital or any particular hospital, but sometimes they are put in bad situations. And I think that they do take on an intense amount of responsibility and pressure to get things done. And so they do have a
Yeah.
need to figure it out because they may not have the tools, they may not have the knowledge, they may not have the people. So they may not have all the things that they need. And so, they're kind of in a traumatic situation and they work through it. And some people thrive in trauma situations and some people hate trauma situations.
Right.
And so that just is what it is. But I think in general, like if you personality test nurses generally, you know, um, obviously saying helping is a weird word. I just took this recent Patrick Lencioni test
Oh
called
yeah.
Six Working Geniuses. And enablement is, that desire to do what you need to do to help. And it doesn't mean enable people necessarily. It just means you like to help. You like to get things figured out and fixed. And
Yeah.
so I just think nurses are naturally that personality type. They're not all the same, but there's a great, you know, percentage of nurses that are like that.
Yeah. Well, so I mean, talking about tools, I mean, alluding to tools, knowledge, resources. I mean, you've worked in academic medical centers, large urban hospitals, and now obviously a rural independent system. I mean, what lessons from those environments translate best to leading a community hospital like Western Missouri Medical Center?
I think I've always felt so fortunate of the experiences I've had. I actually started my career, my first big chunk of career, my first 5 to 7 year career as a nurse, I worked at a community hospital in Kansas City. So they did
Okay.
open hearts and they did trauma, but it was just a private, not-for-profit community hospital, but it was a magnet hospital. So that means magnet is excellence in nursing, and so I really learned how to be an excellent nurse and be proud of being a nurse there. And I really saw what great nursing leadership looked like. And so I feel so fortunate to have seen that, because if you haven't seen it, you don't always know what that looks like. And then I moved on to an academic center, which is where I learned that I like to fix things that are broken. And there was lots to fix there. And in that academic center, I really got this love for evidence-based medicine, like being around residents and med students all the time. That comes with its own challenges, unique challenges, but it is really beat in your head every single day. And I rounded with them as the manager, and so I would hear it every single day, like the evidence behind what they were doing. And
Yeah.
so, and that was a time. I mean, this was probably 20 years ago, but it was a time when evidence-based medicine and the best guidelines and practice guidelines were kind of, really getting mainstream. And so, it became really apparent that if you have a stroke, it doesn't matter where you're at, what zip code, this is how you should handle a
And
stroke.
procedures. Yeah.
And so I really learned that there, and really got that passion for making sure that we're providing the best care to our ability. Not everybody has the same abilities, but you have to work as hard as you can to provide that same care. And more importantly, because that's the care I expect for my family. And honestly, that governs me nonstop. I'm always thinking, like, would I bring my family here for that? Would I do that? What would I need to make that feel safer? And so that's just really important to me.
Yeah. Well, I mean, I imagine taking it's like just like any business. In my business, your business, you work for a really large firm, and then come to maybe a place where there are more limited resources. You carry that with you, right? You carry some of those best practices, and then it's kind of up to you to say, what do we have the resources? What do we have the ability to implement? And what's non-negotiable, right? I mean, what did I
Right.
learn in terms of evidence-based medicine? What do we need to do? So, I mean, I imagine that perspective has just been extremely
Well,
helpful.
and I think at an academic center, for people that don't know this, in my perspective, in an academic center, people are excited to learn. Like they get excited about things. Like, it would take us a year or two to write a restraint policy, because we would look up all the evidence and we would discuss it and meet
Yeah.
and discuss it. And, like, people were really excited to create things and come up with things. And so it was a very creative environment that was really stimulating. And that can be very stimulating. I love actually that kind of environment. That I went to the for-profit hospital, a large tertiary for-profit hospital, from that position, because I knew I wanted to get into an executive leader position, and I thought that I would learn some skills from a for-profit system, and I did. And when I first got there, I had been just bathed in about 7 years of academic, and I was like, you know, oh, so we took our time, we really looked through things,
Now we're just,
and it was like execution was the number one virtue at
yeah,
for profit. Like, you put in charge of something and you implement it really quickly, because honestly, at a system level, I worked for HCA, and I have a lot of respect for the top leadership at HCA, because they are the smartest people in the country. I mean,
yeah,
they truly are leading leaders, thought leaders in healthcare. And so they're kind of up there thinking of all the ways that you should be doing restraints to meet all the best practices. And so you
yeah,
didn't have to do that work. Whereas at that independent academic center, we did all that work by ourselves. And so it's a less creative environment in some aspects. It's faster. The execution, the tenacity to get things finished quickly is valued. And then obviously the expense management, because you have shareholders, and that feels
yep,
extremely different. And so I worked there 4 years before I came here, and I definitely learned so much that I brought here, because I learned how to, you know, be a good steward of my of financial resources, to be honest. And so, and that was very different than how I had seen it at the community hospital, and then the academic hospital, and now rural,
yeah,
compared to that urban for-profit center. So
Yeah, you got to exercise many different muscles before, having to sit in a community and wear those all again, right? I mean, you became talking about different kinds of leadership. I mean, became CEO in 2016, serving as chief nursing officer, right? And so, what did that transition teach you about the difference between clinical leadership and system leadership?
I came out here to be chief nurse because in HCA, that was the path I was on. And my family all lived out here towards where I'm working, and I went to college here. And so like
Yep.
I had this passion for seeing patients that would get transferred in from these smaller communities, and it was always the same tune. Well, they were at X little hospital and they didn't get the care that they needed. And I didn't like that. It really bothered me. And so I thought that I could really add something here. So I became the chief nurse. And honestly, when I came here as a chief nurse, I really still, I was very excited to improve things and think of you. And honestly, here you only have the resources at your fingertips that you reach out to. So MHA, professional organizations. There's no corporate. There's not a leader around every corner in charge of every little thing. So you do have to do a lot of things by yourself. But it was really stimulating, and I was, really engaged in improving core measures in those days and doing things that were really nursing sensitive, which is exciting. And I love that. But I had a lot of operational experience too from being at HCA. And so when they made me interim CEO, I was actually kind of shocked. And what I found was that I loved working with the doctors. That's when I kind of figured out that I really do love working with physicians and helping them to have the things that they need to care for the patients, because honestly, they care so much about having good outcomes for their patients. And so then when I really got the CEO job, and I say this all the time, like as a CNO, I was having fun at work. I'd come to work every day.
Yep.
I would, meet the metrics, do the things, think up all the fun things and was effective at what we were doing. But when you become the CEO, like there is an intense amount of ownership. And I didn't realize that feeling would change because I felt like I was a pretty big owner. I wasn't a renter
Right.
as a CNO,
No.
but I was an owner, but not like I am as a CEO. And I think that people underestimate how that feels as a CEO, because I really do feel like I am making decisions every day that are between my 750 employees' livelihoods and their families,
Yep.
and possibly not. And so that's just one little piece: employees, their families, livelihoods, not to mention patients, quality outcomes. And so it really does. And not that it's all about me. I'm not making all the decisions to do that, but I definitely feel like I have the ultimate responsibility to make sure that I am trying to make sure that we are doing the best we can for patients and employees alike.
Yeah. Well, I mean, you come, like you said, from an environment where you were taking in rural patients and they felt like they had to come there. So now coming back and sitting in this seat, I mean, what were some revelations you've had just over the course of your leadership in different roles where you can say, I've helped to push back on that, whether it be public perception, employee perception, patient perception. I mean, I know that is every rural health organization faces a period where, at some point that comes up, right? I mean, and it varies in prevalency in every different community. And so if you can, I mean, I didn't expect to ask you that question, but kind of what do you guys feel like you've done well to overturn some of that perception there in Warrensburg and for the communities you serve?
I actually talk about this, and in my new employee orientation, and I always say this is an old story, because when I came
Yep.
13 years ago, I really wanted to see what kind of care we give here. I was like, okay, I'm from the city, which everybody knows is better. City care
Yeah.
is better.
Right.
And so I'd heard all these horror stories, and so I came out to like look at the care. And what I found honestly was our med surg care, our OB care, I put it up against anybody in Kansas City. And I really mean that. But what I wanted to be able to do was prove it, like how do you prove it's great care?
That's true.
And so we did go for some certifications, and I do think that while certifications aren't perfect, and they don't mean that people are perfect, when you are desiring and going towards a certification, I think you're getting better even if you don't get it. So even if you don't achieve it, you're assessing your processes, assessing your best guidelines, you're making sure that you're doing the right things. And so we did get Joint Commission disease specific certified in advanced perinatal care, total joints, all the total joints, hips, knees, shoulders. And so that was kind of like the first med surg and OB certification program. And we still maintain those, which requires you to use the best evidence, that you're getting the right outcomes, that you're having performance improvement, which are all the right cornerstones for having good quality care. So I believe that certifications kind of keep you accountable. They keep you going in the right direction if you have the right resources pointing towards those, and everybody from the top down believes in it. If I did not believe in those certifications and I was like, get rid of that coordinator, don't worry about that, don't buy that educational module, then obviously it wouldn't work. But I believe in that from top down because I believe it's an accountability tool for us. But then I really turned my attention to ER, and this is what I'm so passionate about. And I always say the ER doesn't even know how much I talk about them. Because the care that you're captive to in these small communities is the emergency care.
Yep.
I can drive to get a total knee. I can drive to have a baby. But when minutes matter, I mean, time critical diagnosis, and that did report up through me at my last hospital. And so I think that's where I learned that passion. And we took care of them from a tertiary standpoint. So I really learned to love that process. But when I first got here and started looking at emergency care, we weren't doing the best evidence for stroke patients. And, and every one of us in these smaller communities has a grandpa, uncle, neighbor, cousin who has had a less than optimal experience at the local small community hospital sometime in the last 75 years. And I say that funnily, but that's true. Like we carry those memories a really long time. And so I was really on this mission to make sure that we were handling heart attacks and strokes effectively, because if my mom has a heart attack in this community, or if I have a stroke, I want to make sure we're doing everything in our power in the best evidence that we can. And so, we don't ever say, well, we're a small hospital, we do that differently. That's not okay. Like if we can't do it as good as Kansas City, a normal community hospital in Kansas City, then we don't do it here. We strive to make it the best we can. So we started working with, at that time, St. Luke's was our clinical partner. And so we started working with them on stroke care. And we really did do a great job. We got level 3 stroke designated by the state of Missouri. And I think that was just honestly phenomenal. I didn't even know how great that was going to be because the ambulances were passing us, and because we weren't certified, didn't do a good job. They knew we didn't do a good job. They were like, well, they don't give TPA. We're just going to go on to the city because they're not doing the right thing. And so we had to bring in them as partners, get everybody on board. We got certified, which is, and that is a regulation that the ambulance have to follow, those certified center regulations. Yep. And so now we have amazing times. We have amazing processes. Patients go straight to CT. The telebot goes with them. The neurologist is on the bot. They're doing all the things quick. And then we actually have advanced to a level 2 primary stroke center now too, because we do have the ability to care for them inpatient unless they need advanced coiling or those kinds of advanced things that they go to the comprehensive centers for our partners in Kansas City. And so, that one was really significant. And so then we moved on to, I don't remember if we did STEMI, or STEMI was kind of a little one for us because we don't have a cath lab. And so one might say like, well, why did you get STEMI certified? Well, people still walk in having heart attacks. And I need everybody, again, certification makes you better because it gives you goals, it gives you benchmarks, it gives you make sure you're using the right protocols. And so 5 or 6 times a month, someone walks in here having a heart attack, and we need to make sure that we are acting appropriately, giving all the right medications. I don't want the person to get to the next place and them to say, well, they were at Warrensburg and they didn't get the right care. Now they have heart failure because they ruined the heart muscle. I can't, that's not going to sit on my conscience. So we did get STEMI certified level 3. If the ambulance picks somebody up that's having an ST elevated MI, they drive to the city because we know we want the best evidence for that patient. The best evidence that patient goes. But if they walk in and they're having one, we usually fly those patients. We use air transport because they have to get to the next level so quickly. The other day, I had an ER doctor text me. We got someone out door to door having an MI in 24 minutes. And that the next center said that they actually made it to the cath lab with 9 minutes to spare. And so that is making a difference in the quality of care for the people in our community, that care that they're captive to. And those minutes really truly do matter. And so, and I think once you know how to take care of those types of things, it helps you take care of the other things. There's this sense of urgency with really sick patients And so I think our emergency care has really elevated. Trauma was the last one. And I always tell new employees, I wasn't trying to be research medical center or university health, or I wasn't, but 700, we activate trauma 750 times a year in our ER. And they don't all code out at the end as a trauma, but if the ambulance picks them up and they have a traumatic mechanism of injury, they were driving them all to the city. And 60% of all trauma patients across the United States get discharged from the ER. They get scanned head to toe, everything's fine, they go home. So what would happen is our patients would end up in Kansas City and their loved ones would have to go pick them up because they had been dropped off by the ambulance. So we have all the right technology. We have it is a bigger certification because you have to have full general surgery, orthopedics. You have to have anesthesia on board. All the physicians have to have
Should
education.
have.
It's
Yeah.
it's a bigger deal. Your med surg has to be ready for those patients. ICU has to be ready for those patients. OR. So it did take us longer, but we've been level 3 now for gosh, 8 years. And it's wonderful. I mean, it is
Yeah.
literally a wonderful program. And the ambulance and air ambulance, we all work together. So, they know which patients, and we still transfer patients out. I just looked at the statistic the other day. 55% of our patients actually go home from when they get trauma activated here. So they actually go home 55% of the time. I think 22% they get transferred. So if they have any like head, because we don't have neurosurgery here, so if
Yep.
they have certain conditions, then they automatically go. But the other 37% stay. So
Yeah. And you have a way to validate. I mean, I know it's different based on every capabilities for various hospitals, right? But I mean, is that a good percentage? Is that bad? Is that, I mean, it's obviously enough to maintain level 3 stroke, level 3 STEMI, your trauma designations. I mean, you've got a lot going on there. My follow-up is really just from an operational standpoint. I mean, how do you achieve and maintain that with, again, employee turnover? I mean, leadership starts at the top, but what have you seen as trends that have helped you really maintain that level of excellence in so many different areas?
well, I think you do have to have a strong executive sponsor for those kinds of things because time critical diagnosis is so important to me. Like, I think I don't know what would happen around here if that got revoked from us because I would be so disappointed. But so we make sure we have the human resources and capital to maintain that. And we have had turnover, just like you said. We have turnover in the ER just like everybody. And so, but
Yep.
people are proud to provide that care. I never have to worry about time critical patients coming into my ER. If you come in and you're sick or you're having one of those time critical diagnoses, that ER is going to take great care of you because they have the right tools. So they're so proud of it too. They wouldn't not want to do that at this point. And so again, I think those designations just help hold you accountable. And
Yeah.
so it really just gives you a framework, and the state designations are much more prescriptive than just like the Joint Commission disease specific, which really are about practice guidelines. But these statewide ones, like they're like, you will have a fluid warmer, you will have, like
They're
it's
black and
very
white.
specific about what you
Yeah.
need and exactly what education and exactly what resources. And so it gives you the playbook, and then you just have to follow the data and improve where you can. Um, and that's that. I think those percentages, it's hard to say if they're good or bad, but I don't like we don't want to transfer patients away from this
Right.
hospital if we don't have to, because that's our livelihood is taking care of patients. But everybody knows that my intention is that I would never expect us to keep a patient that we can't take care of in the
Right.
best manner. So
Right.
if we don't have the ability, it leaves. And that I think that everybody stands behind that. Like we want to take care of patients, but we want to take good care of patients.
Yeah, you have that autonomy, right? To decide what are we good at and where do we need partnerships, right? And that I think
Exactly.
we'll get into that. But I mean, I mean, heck, staying on independence. I mean, you guys are county owned, independent health system serving Johnson County and the surrounding, we'll call it surrounding communities, right? I mean, what is that when you think about independence? What does it allow you to do as a leader? And then, maybe contrast that to what it looks like under some sort of partnership model, right? Or as a hub and spoke model of a larger system.
You know, yeah, we own a couple of primary care practices in Lafayette County north of here. So we do cover a service area of about 60,000 lives. Whiteman Air Force Base is right by us, which is a
Yep.
huge part of our services that we provide and that we maintain to provide those services for Whiteman Air Force Base. Um, I strongly believe now, and I'm not saying that I'll never have to affiliate.
Sure.
Um, I don't think any of us in this day and age can say that with 100% certainty. There are some really, really big mergers going on with billion-dollar health systems joining other health systems, and so consolidation is happening swiftly. In my opinion and experience, being independent allows us to make sure that we are being able to prioritize the care that we think is important in our community. We did have a clinical affiliation with the Kansas City system at one point, and it was just a clinical affiliation.
Yep.
It wasn't, they didn't pay our bills. They didn't, we didn't pay them necessarily they didn't manage us. However, they did provide some specialty physician support and those kinds of things. And what I really found in that experience is that you cannot be too dependent on any one partner,
Right.
because then honestly that air of competition kind of goes away. And so they don't really have they're getting your business. They're doing the best they can. They're going to serve their market
Complacency.
before they
Yeah.
serve your market. We just added a PET scanner. If we were being managed, not managed, because managed, you still get to make local decisions. But if we were purchased or acquired by a system, I don't think they would be putting a PET scanner here, because they would
Right.
say, well, do you really need a PET scanner?
What's the
Because you
ROI?
can get
What's
one in Lee Summit. Why don't you just drive to Lee Summit? I
right.
firmly believe that anytime we put somebody in a car and tell them to go get care in Kansas City, we're actually telling them that our care is not, like, there's maybe some cracks in our care.
Right.
They're like, well, if they can't do that kind of ultrasound, then can they do anything else? So it just encourages some distrust in our abilities. And so that's like my mantra too. Like, if you're telling them to get in the car, you're probably inviting them to get all kinds of other care. But so I think that the ability to, like, OB services, there's a lot of hospitals, small hospitals across America, that are closing their OB services. There are several of us regionally that have hospitals that have OB services because we're independent and we can make that decision
Mhm.
for ourselves.
Right.
I guarantee if the three regional hospitals close to me, three to four, if we were owned by other systems, we would not all four be
Right.
delivering babies.
Right.
And that does affect your community. We deliver
Yeah.
700 babies a year. We deliver probably 250
Yeah.
Whiteman babies a year. So that's a significant service for us. It's not a huge moneymaker, and any
Right.
hospital administrator knows that. But it's a service that we get to choose to spend money on because we think it's important. And I just firmly believe that, and I didn't look it up, but I've read before some statistics about if you become acquired, it actually increases your chances of closure. And so it not having shareholders makes a difference. You
Right.
don't have to worry about some of those things when you're making some decisions that may or may not make a ton of money, but it breaks even and it serves the
Yeah.
community. And not having some other overarching person that's making allocation of assets decisions for you, you know. So
Yeah. Well,
I think there's just benefits to be able to do it yourself. And I do tell my public that all the time. Like, our whole goal is to stay independent as long as we can. And
yeah.
so we're doing everything we can to stay independent. Our physicians want to be independent. They don't want to be rationed for the things they can do, I say
Yeah.
toys,
Right.
the tools
Well,
that they can have to take care of their patients. They want all the things they want to take care of their patients because they want to keep their patients here too, under their care,
right.
and serve this community. And so it's just so important that we are able um, have the right partnerships, have the right collaborations, but be able to control what we're providing for our community.
Yeah. Well, I know there's a lot going on in that space to try and refine partnerships and what that's going to look like over the next couple of years, and again try to combat some of the headwinds from a financial standpoint. But I mean, you guys have your own mission statement, right? The outward mission statement of a, I'm not going to say by name, even though I think you alluded to it earlier, of a large system, publicly traded, trumps their shareholder responsibility, right? And so, to your point, if you have a mission statement that incorporates caring for your community, bringing the healthcare that's needed there, that'll always be combative to, you know, service lines that just aren't profitable, right? And so thereby posing a conflict of interest. And so, I love how
It
you
is. And
outlined that.
everybody serves their part. Like, we need the for-profit systems. We
Sure.
need all of those players, but it is different. And I always tell new employees, there's everywhere you work, there's a mission written on the wall in the boardroom. And then there's this mission you feel when you're working there, and sometimes they don't match. What I am kind of proud about is our mission is strongly around serving our community, and you feel that. Like even in our employee engagement surveys, 29 people on our last one said the reason they love working here is we take care of our community and our family. So they do feel that
Yeah.
we are here to take care of our family, which is our community. And so I do feel like that feeling is parallel. It's correct.
Yeah. Well, it's got to help in, I mean, talking about something else in the way you recruit, retain, attract new talent. I mean, since joining Western Missouri Medical Center, you've recruited more than 2 dozen providers, maybe more by now. That's just the data I was able to scrub and strengthen the physician enterprise. So, I mean, like what outside of this, awesome culture you're creating, what strategies have been most effective in building a strong medical community there in Warrensburg?
I think I think part of my physician strategy comes from me being a nurse for 30 years. Like I have a really high level of respect for physicians because 30 years ago, you really did get out of your seat so they could sit down. Like it was a different day. You go get their coffee and follow them around. And so I was brought up with a deep sense of respect for physicians. But I also had a really good CEO at the last hospital I worked at that he had a really strong relationship with physicians. And so I really thought about that when I took over here. Like, what did he do? Like, what did that look like? And we talked about it. I called him and picked his brain. And we were right when I took over, the local practices really all came forward and said, we're not going to be able to recruit for ourselves in this day and age. We're not making enough money to recruit. So we're interested in being purchased by the hospital. And so we went through the process of purchasing all the primary care in Johnson County. And then, like I said, 2 practices in Lafayette County. And one of their biggest fears was, I don't want to be told how to practice. You know, they also wanted to maintain their sense of independence. And so how do you help them maintain their sense of independence, but also join together to do what's best for the community? And so one of the things that a mentor CEO of mine did was he had what he called a kitchen cabinet, which is modeled after Harry Truman's kitchen cabinet. And so he had a group of leaders that would come and meet with him every couple of weeks. And that was kind of his sounding board for all kinds of things, like,
Ah,
hey, I
okay.
don't know if this is working. What do you guys think? And they could have some really frank discussion, just him and them. And then at another system that we worked with, they actually had a physician enterprise, they called it. And so we had them come out and talk with our physicians. And so we created our own physician governance structure, at which we do call the physician enterprise. And it's made up of a couple of committees that have people that help, like we have an informatics medical director, we have a quality medical director, we have a physician who leads our medical staff development. And then we have a practice operations. And so we have these 4 committees. But then they roll up to those chairs set on a physician leadership council, which is kind of my kitchen cabinet. And
Yeah.
so that is where I go and I say, hey,
Mm.
XYZ, and I give them the data. We talk about physician compensation in there, what our strategies are for compensating doctors to attract them, for our strategies in retaining physicians. We talk about the services because people want to give good care in good places.
Yeah.
You can't and by the way, you're not going to have good nurses if you don't have good doctors. So it all goes together. So you're not going to have patients without doctors. You're not going to have good nurses without good doctors. Like it all goes together. So I just think physicians are so, so important. So I think one of the secrets of success is this enterprise, but not alone. It's not
Right.
just the enterprise. It's that I believe in it. I mean,
Yeah.
truly. And I really do like to have a relationship with the physicians, which is probably why I don't work at a bigger hospital, because if I worked at a really large
More.
hospital, I wouldn't know 300 doctors,
Right.
um,
Right.
not personally, but I do know, the 100 we have employed plus the others that come in and out. And there's something about knowing the person that controls your compensation and your work environment, and knowing that they can come to me and I know that I can go to them if I need help driving some sort of outcome, and we work together, and it's really such a beautiful thing. And when I hire physicians that come from bigger systems, or even not big systems but maybe not with the right structure, they say, I never got to talk to the decision maker. So I would tell my practice manager, I hear this from people all over. I would talk to my manager. She'd say, well, I need to go talk to so and so. And then they talked to so and so who had to go talk to so and so. Well, by the time it got up, the physician's so frustrated. And by the time that gets to the person who really gets to make the decision,
Right.
they don't even understand it.
It's
It
been
doesn't mean
exploded.
the same when you're not hearing it straight from the physician. And so I think that that's been, and then those physicians, by the way, then it just starts taking care of itself. So then they start recruiting the next
Right.
physician. So when I bring new physicians in, I just introduce them to the ones I have. And so I have a pretty young medical staff, you know. We don't have per se an old guard,
Yeah.
really. They've retired. They helped us set this up, and then they've all
Yeah.
sort of moved on, and they love the medical community that we've created, and they wanted to see that happen for the future for this community. And so now they just recruit each other,
I
and
mean,
it's a beautiful thing.
yeah. Well, and I would even question, like, even early on when you were acquiring practices and there was that fear from, or fear as you call it, from the physicians who say, I'm going to lose my autonomy. I mean, how many would you say had a reversal, a 180 of that? They realized, hey, I got out of the weeds of all the stuff I didn't want to do because now I'm working with a system that's going to help me and support me so that I can worry about patient care and do the things I need to do that have given you all of these, accolades and attributed to this cohesive nature that keeps you guys at a very, very high level from a quality and excellence standpoint.
Well, I'm not going to say it's perfect, because
Yeah.
there comes other frustrations. Yes, they get to worry about the patient. They don't have to worry about making payroll in their practice, and that was a big lift for a lot of them. However, there comes other
Right.
frustration, like one EMR, so they all had to switch EMRs or get an EMR. And then so, there's other frustrations
Sure.
that still have to be worked through. And so I think it did take a couple of years at least to really gain the trust that we needed between all of us, both sides. And so um, I think that now, I mean, that all happened in 2016. So it's been 2 years, 10 years. So we've been going at it a long time. We had quarterly med staff today, and
Oh,
I
okay.
am very transparent with them. I tell them, and that's the whole medical staff. But it's a good group.
Yeah. Well, I want to talk. We've been talking a lot about quality and how you've gotten there. I mean, what I don't think we've touched on is you guys earned CMS 5-star hospital quality rating last year. Congratulations. What does that designation mean? What goes into achieving that level of quality and performance?
I wish I could tell you, Brendan. Um, it is a complicated rating system. And I felt really fortunate. We were always a 4-star here, which I was proud of. And matter of fact, by the way, we are 4-star right now. They just got released and we're 4-star, and we were very proud.
Yeah.
But twice in 2022 and 2024, we were named 5-star. And it's based on, I mean, real metrics, readmissions, patient safety,
Yep.
all those quality indicators that are publicly reported. So it's real stuff. You can't game it. It's real. It's from the claims data. Um, it's hard to monitor real time if you don't have all the right electronic tools. So, if my patients get readmitted to Lee Summit, I'm going to get charged for that readmission, but I didn't really know it. But there are tools out there coming, and like
Yep.
one of the electronic records that we're implementing right now, we'll have better data around that. But so sometimes it's really hard to manage. So you just have to do the best you can, and you're like, ooh, I hope that comes out. And I hate to
Yep.
say that, but I know that there are a lot of us that feel that way. Um,
Yeah.
I think that it is really prestigious, honestly, to be rated a 5-star, because it's usually delayed though, so like the first time we got it, it was a delay because of COVID. And so they put out this rating after they hadn't put one out in a while. And I remember I was feeling really down about what we were doing. I was feeling very mediocre. And then they're like, you're a 5-star. And I was like, oh my gosh, like
Goes to show.
that ruined my mediocre speech to everybody, right? But it is like we were one of 13 hospitals in the state of Missouri that got 5-star.
Wow.
And so it is prestigious. And so it's always a goal of ours. But I am very proud. Believe me, it's not easy to achieve 3, 4, or 5. I mean, to be honest, like it all takes
Yeah.
work. And and they actually just changed the system a little bit. So there's like it's like a gated theory where you have to beat certain things before you even get rated. And so they're fine tuning it. And
Yeah.
so more understanding I think is coming with how to get there. And
Yeah. Well, I was going to say with AI, I even know of a company, and this is not to publicly, put up a billboard for them, but Garner Health, who is basically partnering with health systems to help them to do exactly what you're talking about. And it's new. They had to partner with a couple of large systems to be able to say, hey, let's give hospitals a sniff test, how they're doing, and compare that to the data that gets aggregated together to produce these scores. And so, to your point, I mean, with all of this information coming, I didn't even ask the AI question. I don't know if we want to go there, but and what that means for healthcare and you guys, but I know I can corroborate that, right? That's coming around to where you'll be able to say, we don't really know, but now we do because it's real time data. We can get out ahead of what they're actually aggregating from the claims warehouses to come up with these
well, and
metrics.
that's better for care because
Yeah.
I mean how we keep ourselves maintaining is like, if around any season of time, you have rigorous performance improvement. You are doing after actions. You are escalating events that have harm. You're doing all those things real time. And so you have the right processes in place to do those things, but it is hard.
Yeah.
Like I remember the first time, I mean, I dig out there all the time and look for different things. And so one time I came back and I was like, guys, we have a high DVT rate. And everybody was like, what are you talking about? And it was hard to get to. So but way after the fact it was kind of hard to get people's attention that we had a problem from this metric that I just happened to find out on some publicly reported domain.
Right.
But I do that, like I look at that stuff. I mean, I'll scour anywhere and send
Yeah.
it to my team and they're like, oh gosh, she's on the internet again. But
Yeah.
it's not stuff. Sometimes someone's gathering it, so it's real.
Yeah.
And it's obviously not on our radar, but it should be. And so I always, you want to improve everything you can so that
Yeah.
you're not the patient that gets the DVT.
Right. Well, I mean, you're talking about, hey, let's improve as much as we can. Let's make sure we offer the highest quality. And you talked about evidence-based care earlier on. How does all of that? I mean, obviously, you would hope to have as high a quality, the best resources, the best technology in any situation, any line of care that service line that you maintain. But how does that decision making pair with hospitals who are facing unequivocally financial and workforce pressures, right? I
Sure.
mean, um, that has to come into play with every decision, I would think.
It is. It is. I mean, I think that that's just like what I was just saying that, you have to have those structures in place so that you can keep an eye on it. So you have to have good performance improvement, good metrics, good dashboards so that, in ER, for instance, we were just having an expense reduction campaign around here, which you just should do regularly just to make sure you're doing things good. But we had a special one and we were talking about staffing and the physician staffing in ER. And so, do you give them more? Do you give them less? What metrics are we going to look at? How will we know if we went too far? How will we know if we made a difference? And so you do have to constantly be looking at certain metrics or, a set of metrics and trying to improve those because if you don't, then you don't know. If you're cutting staffing, but you're not measuring quality, you don't know if you went too far. Um, and if
Yeah.
you're having significant financial constraints, which we have to make hard decisions, we have to be willing to as CEOs, but you can at least have the data to be like, okay, we cut the med surge staffing and now our falls are out of control. Let me dive deeper. Where are these falls happening? And
Right.
then prioritize or not prioritize whether, so you just have to keep up on the data or you don't even know where to prioritize it.
Right.
So I think having that performance improvement and quality assurance structure, and that's just something when I talk about leadership development, I think because leaders don't come out knowing that. They don't, I actually wish that like nursing students, I always think that if I had nursing students come here, and we actually did this at one of my hospitals, we had nursing students come during their really, really early and teach them how to look up policies and how to like look at what that means to care and what that means to metrics and how do you improve that. Because you don't come out with that knowledge. And so every leader has to learn a framework of performance improvement. And it's a struggle because everybody's in a different learning, they're in a different path, they're in a different spot. And so some people are really sophisticated at it and they know how to do it. And then there's others that are like, you know, lost in the forest
Yeah.
and they don't really know what they're looking at. And so you do have to have a really strong quality leader. You do have to have good leadership in your executive level to push people to identify metrics and be watching those.
Yeah. Well, I imagine it comes down to communication, right? I mean, you probably in your seat and validate this, please. But biggest part of your job is being a fantastic communicator, a fantastic educator, right? Because you're dealing with individuals at different levels, right? Um, in terms of, to your point, coming out with none of that operational, um, you know, none of that experience to be able to say these are the things we need to be looking about to make improvements. I mean, talk a little bit about that, your communication style, what you employ with your management team, your physicians, if someone asked you just blatantly, what's your communication style? How would you answer that? And what do you think's effective?
I think I think you can always do better, no matter what you do. But I am a very transparent person, and I've always talked too much. It's just who I am. I don't lie because I don't like to be caught in lies. So that's number one rule, right? So just don't lie, and everything's fine.
Yeah.
But we make hard decisions, and you have to tell people why. And so that's the biggest thing. I think that what I do well is if I have the opportunity, like in road shows, in birthday breakfasts, which are just some of the things I do with frontline staff,
Yeah.
I get to know them. I answer hard questions. I tell them the why. Sometimes it gets me in trouble. I'm not perfect. I answer the question, then they leave. Before I know it, the whole hospital knows. And then some other department's like, she didn't tell me that. And so it's not perfect. It's
Yeah.
not perfect. Like, but I feel like if you're too measured with it, you're you're not going to hit it. You're just not.
Right.
You have to be authentic and answer questions
Right.
because if you're not answering questions, then people think that you're not truthful. They don't trust you. And so I do answer questions and then I really quickly run right back to my leadership team to say, "Hey, this is what I said in that breakfast. So let's make sure everybody
Right.
knows what I said because I don't want anybody to be caught off guard." But I try to give as hard as I can. I try to give early half-baked information, which I know sounds crazy, but particularly to my board, to my leadership team, to my physicians, frontline staff, you have to be careful of make them too nervous. But like, I want them to know, here's what I'm thinking. What are you thinking? Like, what do you think about that? And so I like to give that early half-baked communication so that I can get a feeling for where they're at with it, and then I know
Right.
how to communicate it better, or I know how to structure the rollout. And so I think that's what helps me figure that out is that I've already talked about it.
Right.
Once I tell you, I've probably already mentioned it to you twice. And so I already know kind of how you're feeling
Gauging.
about it.
Yeah.
And so then
Yeah.
I know how to approach it. I think I wish I was better at being with more frontline people. We can't be everything to everybody, but I do wish I shadowed more. I wish I committed more time to that because I think that when you sit down next to somebody, I think rounding is a huge waste of time because people are busy.
Right.
If anybody shows up at my door unexpected, I don't have time to talk to them. So when I walk up on them at the desk, they don't have time to talk to me. And all it does is hurt my feelings, because I'm like, well, they weren't very nice or they didn't want to talk to me. And so unless I really, really know them, I don't like that. I don't like that rounding. And I know that that's kind of controversial to say. But what I do like is sitting down next to them and watching them work because then they get used to you. They get a little comfortable with you. And then you really see, like
Yeah.
during COVID, I did it quite a bit. And then you're like, guys, they're not wearing their eyewear. Like they didn't even know to hide it from me, but they're not
Yeah.
wearing the eyewear. And so, but they just get comfortable with you. And so I
Well,
think they get to know you better. And then they're like, okay, she's not that scary. Because whether I want to believe it or not, the CEO is scary. And
Yeah.
so I would wish I had more time to normalize that environment and that communication with frontline staff. But
Yeah.
I do focus a lot of my attention with physicians because I feel like that's kind of my job. And I have a physician leader also that helps with that. But that's probably I make sure that I'm trying to get front facing with them as much as I can. And then I think my next priority that I could always do better is those middle managers. And I think this is a gap. Like my senior leadership team is amazing, my executive team, and I communicate with them all day long, every day. They know exactly what I'm thinking all the time.
Yep.
But those middle managers, the ones that are down there with the staff, I think we could all do better at making sure they hear the message and the mission from the top because it does get lost, you know,
Yeah.
as it moves down. So that's kind of my approach. Just keep
Yeah.
talking. Just keep talking. That's my
Just keep
approach.
talking, getting involved, and before long, like you mentioned, your fellow employees will view you like a colleague, right? I mean, because last thing you want
That's
is
what I
right,
want.
right. You don't want you're not. It's not a gotcha moment, right?
Mm.
And as long as your employees don't feel it sounds like you're doing an amazing job, just kind of getting to that, spending more time. Obviously, you can't manufacture more time. I'm sure that's something you wish you could do every day, but uh, yeah, I mean, it sounds like I mean, for other leaders listening, you've got to find time to develop and nurture those relationships and be strategic about it, right? I mean, I imagine you spend time blocking, right? I mean, I'm assuming otherwise it won't be intentional and it just won't happen.
You have to, and that's the hard part because we have full days. I mean, um, it's hard to find the time. And honestly, that's so like I just got back from Congress from ACHE
Mm,
and I came back and my one thing was I am going to shadow more. I'm going to get out there and I'm going to shadow more. Um, Not so I know what they're doing or got you or any of those things, really just to connect with people. Because you do understand the work differently. And I love patients. So I love doing the work with people. Being right there next to them. But I really want to do that. And I think that we trip ourselves up because we try to commit too much time to it.
yeah.
So I'm kind of like that. I'm an all or nothing. I'm like, well, I can't do it every week, so it's failed.
So might as well. Yeah.
Well, even if you do it one time this year, that's better than none, you know?
Right.
And so 2 hours is better than a 12-hour shift, you know? So like just even those little, like I have an hour, I'm going to pick the departments I'm going to go to this month, and then you just go. They don't love to see you kind of spur of the moment. But I am always hesitant to say, and my employees, when they hear this, they're gonna be like, that lady is never out here. It's hard, but
Yeah.
I don't, it's hard to also schedule the time because then what if something happens?
Right.
What if, what if Brendan Hurley calls and says he needs to have you on a podcast and then you reschedule a million times? And so it's just difficult. But just like anything, you have to make it a priority. And so that's something I beat myself up about all the time because I feel like I could do more.
Yeah. Well, talking about priorities, I want to switch gears a little bit. Priorities of the foundation, right? I was blessed to and excited really to come out to Fire and Ice this past year. Shout out to Callahan Taylor for looping me in and having me come along. But I mean the Empower through early detection, right? I mean you guys were investing in breast imaging technology, right? So it's an initiative that's expanding access to all of that type of tech. And so I mean tell our listeners about it and why it's a project that's important for your community. I got to hear it firsthand, but go ahead.
Anytime our foundation revived themselves, actually right about 10 years ago, 2015, right before I took over, we revived this older organization into the foundation. And so it's sort of in its current form, kind of young, but what I'm proud about is everything that they raise money for, it's always to help, honestly, physicians treat and care for the
Yeah.
patient, whether it's a e-bus for the pulmonologist or a PET scanner for the oncologist. Like we're always trying to put those tools so that I can help recruit. Because if you don't have those tools, they don't come. And so most recently, we finished our PET scanner where they purchased a PET scanner for us and we put that in, which was important because we wanted two CT scanners in the building with the PET scanning ability. And then we had started Ladies Night Out 14 years ago, which is an annual event. It's an educational event that the hospital puts on to encourage. At that time, our community health needs assessment showed that we had a large number of late stage breast cancer at detection. And so we weren't catching it early. And so we needed to do more mammograms. And so we started this Ladies Night Out as an educational event every year. So like this past year, we had over 800 people come. It's a very fun event. We have a survivor speak. We have, fun things there, food and festivities and fellowship. And it's a great event. Now, with that, we've grown our mammogram need immensely. And
More
so,
detection. Yeah.
more than we're doing lots of detection. And so we've had 3D mammography for about 10 years, but we really needed two to keep up because we do also have a lot of diagnostics too. So like if they find something, you have to get them in quickly.
Right.
And so all the things. And so we really wanted two, and we wanted to get the newest and best technology. So the foundation committed to $755,000, which purchased us two new 3D mammography, one with, I'm going to forget the word, the biopsying, I don't got the right word.
Sorry, if you're looking at me, I'm not a clinician, so but
It's like node biopsy. I can't think
yeah,
what it's called. But it has that capability, which we haven't had in a while. So we used to have like a trailer that came and did it, and that business went out of business. And so anyway, so we want to bring that back. About 4 patients a month we have to send to the city because they need that. And so I can't remember the word, but that's okay. So two mammograms. We've already purchased one. So we built another room. We moved some things around, made some space. We have two going now. So we have our old one, still with 3D, still good technology. And then the new one, not the one with the advanced node biopsying,
yep.
but we have two running. And so we're totally caught up. We were like 6 months out on screening mammograms
Wow.
before, and now we're, within a week or two. And so that's been an outstanding result to help our community. And honestly, this last year at the foundation event, Fire and Ice, and at Ladies Night Out, our survivor that spoke, she is a Whiteman wife. She moved here, got stationed the first week. She like scheduled her mammogram here. They found cancer, triple negative cancer. She had all of her care here that she could have here, and it was a great experience. And she credits, her life to the life-saving things that happened here under the care of our oncology team. And honestly, it really touched me because people, just like you touched on earlier, that people kind of get like, well, is the care better in Kansas
Apprehensive. Yeah.
City? So they're really apprehensive about their local hospital. These airmen that show up from Whiteman, they're captive. They just drop in here, and she just came to our door, and she depended on us to be using the best evidence, the best tools,
Yep.
all the things. And so it really touched me. And so it was such a great story about how we impact so many
Yeah.
people unsuspectingly. And so really encouraging that early detection and mammography is important to us. And so we're almost done I think they have less than 200,000 left on the project to finish out getting the last mammography machine. And they also bought a specialized ultrasound machine for dense breasts. So, so just lots of things to help us do more diagnostics, help the physicians get to the right diagnosis quickly. But then it's always a bonus if you can also increase revenue. So if they can purchase things that help us do more testing, then it's going to help our bottom line too.
Yeah. Well, you were able to deliver on these things that you thought about, and it doesn't happen overnight, right? I mean, I'd love to get your perspective and know that or think that I'd maybe ask this, but I've heard about your foundation, right? I mean, and the cool things and how you guys have transformed that where it was, right? I mean, you alluded to it briefly. I mean, for those listening who are starting foundations or who maybe have one, but it's just lackluster, or maybe they haven't put in the energy. What would you say? How would you say to approach making the foundation impactful? And then what's worked well for you guys to really get meaningful outcomes out of what the foundation's able to accomplish.
I think so. We did originally hire a consultant to come in and help us who concentrate on rural healthcare, and so they had really had this very specific regimen of activities that help to engage a community in a rural health um, institution. And honestly, I believe in it. So theirs is it's a volunteer-based model. So they believe in lots of different. I might say five. I'd have to count them because they've morphed a little bit. But there's committees of people. So there's like business development. There's major gifts. There's annual support. There's an employee committee, and so each one of those committees. They collect people, they recruit people from the community to be
Yeah.
volunteers on those committees. And so pretty soon you have a group of 75 Indians that you are telling about your institution monthly. I go to the meetings and honestly, I don't have to as much anymore because it's baked. But in the
Yeah.
beginning, it's honestly one of my favorite things to do. The foundation things are like one of my favorite things to do. But going to the meetings and giving them kind of a little, you know, bird's eye view into what's coming, or they love that. And we give them behind the scenes tours so they see the hospital, and not one person has ever been through a behind the scenes tour that was like, oh my gosh, I had no idea that you guys did this. Or it helps them see that we actually do, there's a lot of thinking behind the things that we're doing.
Yeah.
And they're like, oh, people here are smart. I hate to be like that, but it some
Perception.
people, the perception. And so them meeting our director of diagnostic imaging and them talking to physicians on the tours and physicians who are on the committees, like it really, really helps them understand the passion and what we're here to do. And so then it's a real easy sell. And so 75 people before you know it are sitting on these committees,
Yeah.
and now they're part of it. Now they're part of WMC. And so that's a little harder to complain about.
Mm.
That's a little
They're
harder for them.
taking ownership. Yeah.
You're taking ownership. And so I think that that's so important. Um, and then it just goes from there. We've the major gifts. We have a giving club. Their Pillar Society. I think we have 140 people committed to $5,000 or more on pledges. It's a lot of money.
Yeah.
Um, they're a big powerhouse of the money that gets raised, but we have a ton of annual support. Annual donors, what the statistics show you is that someone who gives $100 gift, like statistically, people who end up giving you millions when they die gave you like $100 gift at some point in their life. And
Yeah.
so like getting those people in those little $100 here and there is and then following up and doing all the right things
Right.
is really important. But for me, it's been a good friend raising effort. And so it is meeting people in the community,
Right.
inviting them in, telling them about, showing them how passionate I am, talking to them about all these things that we've just talked about. Like everything
Yeah.
we talked about, I talk about at different meetings. And so they can see that I'm passionate about it. Like we all care about it. The physicians care about it. We're here to grow and stay and remain independent in this community. And they want to be a part of it.
Yeah. Well, I mean, business, I'm sure whatever I've experienced, you've experienced tenfold, but I'm engaged with my local hospital, right? I mean, and coming to fundraisers, I've been on one of those committees, and it's oftentimes interesting to talk to some business owners who think, even in the community, right, that, well, it's the hospital. Why would they need my support, right? Why would they need my support? They certainly charge enough, right?
Right.
And once you go through and target especially those individuals and say, why don't you come on to a tour? Why don't you come out to our event and hear these stories, hear what's going on in your own community, and watching that flip. And I've got a few people in mind that I know of that I've seen this happen. I'd be curious, if you've had the same experience with some maybe even high profile folks in your own community.
Absolutely, we have. And it takes time. It takes trust. And I always tell people in the foundation tours and the committees, like I'm like Shane Co. You got a friend in the healthcare business. So if you meet
Love
me,
it.
I want to know. Like if you come through the ER and things aren't right, I want to know because I want to make things better. And the only way we can make things better is if we know. And so I think it does empower people to use our services and to we have one really prominent member in our community. He was really active in the board, the foundation board, and he had gotten all of his orthopedic care in Lee Summit. And people don't just change orthopedists. Once someone does your knee, you're going to go back for the other
Yes.
knee. Like that's your guy. But he switched all of his orthopedic care, which it sounds funny, but he gets a lot of orthopedic care.
Huh.
And so he switched it all here, and he's like raves about how wonderful it is. But he would never have done that if we hadn't made that connection through the foundation, and I hadn't, and we hadn't made that friendship
Right.
with the organization. And so, but people want to know that the people running the place care, and that we're using the dollars correctly, and that we have the right mentality, and that we want to make things better for the community. And so I think, again, executive presence in foundations and physician things, I just don't think there's anything more important. I really don't.
Yeah. Yeah. Well, it's all about, I mean, again, it starts with leadership. In fact, I'd love to zoom out a little bit in terms of, your leadership there at Western Missouri, but at a state level, you just talked about coming back from the ACHI conference. I mean, you're a fellow of the American College of Healthcare Executives and a regent for the Missouri chapter, right? So,
Yeah.
which that kind of gives you a front row seat to leadership development across the state. I mean, what does that role involve? What are you seeing, stepping into rural healthcare leadership roles like that?
Well, I first of all, I had a really strong mentor, that another CEO of a rural hospital who had been really involved in this, and she mentored me and encouraged me to get involved, and it's been such a rewarding experience. So ACHE, honestly, their whole mission is to be a connector in improving healthcare, and so connecting, clinical excellence with leadership development, and really bringing people together to make us all successful. And so at the national level, as a regent, I represent Missouri. And so I sit on the Council of Regents, and we brainstorm about what does ACHE development look like? What do the future leaders need? What
Yeah.
should the focus be? So we have like think tanks and some things like that. And that's obviously, those things are stimulating, and I love that stuff. But it is real. Like, they really do want to make a difference for healthcare leaders, early careerist and up. But I do find that ACHE is really, really important for early careerists. I think that is, helping to develop early leaders is one of their main focuses, because, and that's who really needs that networking, that education. And so we have chapter in Missouri. We have one chapter that's a whole state of Missouri. And I don't know if you know this, but Missouri's pretty big, to like try to organize one thing for the whole state.
Yeah.
But we have different chapters for what we call programming committees. So we have a Kansas City chapter, we have Columbia, we have St. Louis, we have Southwest, which is Joplin, Springfield, and then we have Southeast and Cape. And so we have programming chairs in those areas, and we hold networking events, educational events, and it really is all geared around helping people connect with other leaders, and get educational hours. And then we also hold, annually, the Missouri chapter has a review course for the fellowship, for the fellow exam, the Board of Governors exam. And so we do that annually, and it's a really nominal charge to do that. And it's a great course. And so, helping people to get prepared for taking the exam, and then networking with other people, and then keeping their hours up to keep their fellow. That's really their goal. Is so networking, educating, connecting people.
Yeah. So, I mean, so when you talk about this, because for those listening that may be interested in leadership, or, I mean, there are different places amongst their, maybe they're already in leadership, right, and getting involved. But what are you guys seeing? I mean, in terms of, I mean, yourself, you came from a clinical role. We've seen other leaders come from a legal background, or then maybe they got their MHA. They always knew they wanted to be right in healthcare administration. I mean, how are you? Who's getting involved? I guess, is it folks that already know they're interested, or are you doing, you know, making an effort to recruit folks in, because you've got to make up for a gap, what's likely a gap coming, right, of folks that are interested. I'm
It's
assuming.
both. We have a student committee that I'm actually involved with. So Missouri chapter has a student committee, and every chapter is a little different across the nation. But our student committee is ran primarily out of the SLU student MHA
Okay.
program. There's some really active students there, but we have some from MU, we have some from MSU and Springfield. Like they're from other colleges, but um, so they meet every 2 weeks. They are constantly trying to reach out to other programs to connect with other programs. I went with some students to visit MU, some their MHA program. I had an appointment at Drury. We had to reschedule that. They did a presentation at SLU. We did, so we're always trying to bring other students in, and students are really excited to do it because the MHA students because they want to be healthcare leaders and they're not quite sure how to get there always. And so they're like, this is
Mm.
the good path. I'll meet people. I'll be able to network. And so that's one thing. I think that we have tried at the national level and the state level we did a networking event last year in Kansas City that we tried to partner with the MONAL or the nurse
Oh,
executive.
yeah.
There's also a CNE nurse executive council in Kansas City. So we tried to bring like because, these organizations, professional organizations, they aren't really cheap. And they each have their own, you know, priorities and that we're all going to the same place. But some people are involved in AONL or, for nurse executive or nursing leadership, and they are doing their conferences and so I think at the national level, we're talking about how do we bring those together? How do we connect
Yeah.
those people?
Yeah.
Because physicians are teaching their leaders and nurses are teaching their leaders and,
Like,
so it really is. So ACHE, I think traditionally has been mostly operators. They've been MHA,
yep.
MBA, operator type people. Um, but I think it's really important. Like at my regent table just this last month, there was a physician leader sitting next to me as a regent. There was another CNO that was at my table that was a regent. And so, we felt like we represented a little bit differently than some groups. And we think that's important because we just bring something a little bit different perspective.
Yeah.
Um, and so,
I
and
mean,
that's what ACHE wants to do.
yeah,
So,
well, it's interesting, this is early on in this podcast, right? But the professionals, none of, including yourself, the professionals I've worked with or had a conversation with, have that was they didn't go get their MHA initially, right? That this was a progression into this role, and I imagine even just the initial conversations I've had more broadly, especially in rural areas, that's a more common theme. That's a more people, folks are inspired into leadership, and so I imagine this group is something of substance to get engaged with to pursue that path, especially again if you didn't have a go to school, get your master's in healthcare administration and all that good stuff.
right. It is. I mean, it really does expose you to lots of different things. And there's wonderful content at Congress. We're trying to work on how to make that stuff more accessible because there is cost. And we know every healthcare organization across America is trying to cut costs and sometimes travel's cut and those kinds of things. So that's definitely a mission of ACHE. And I don't think that I think the FACHE credential is still widely accepted as like kind of the gold standard
Oh, yeah.
for being a CEO, being a seasoned healthcare executive. And so it was a difficult exam for me. And I'm a good test taker, but I'm super proud of what it represents and the group of colleagues that I get to work with because of that affiliation.
Yeah. Well, I want to shift to, we've talked about kind of looking back and your history, looking ahead, right, to the next, call it 3 to 5 years. I mean, what opportunities excite you most about Western Missouri Medical Center, the community you serve, and even maybe just more broadly, the rural healthcare landscape?
I mean, exciting is an interesting word, Brendan. I like to call things that are going to be hard stimulating
Yeah.
instead of exciting. But it is.
Yeah.
It's a stimulating time. Reimbursement is more and more difficult. There are hospitals closing. There's hospitals, merging,
At
and so
risk.
I think so. So it is. it's a time to be aware of what's going on and to be try to be a part of that. I think we have some wonderful healthcare leaders. I honestly feel so novice compared to the CEO group of friends I have in the state. Um, and I feel blessed because there are some that are really good at political things, at lobbying, at making sure they're working with our legislators. And those are things that our staff on the ground here, they don't even think about. But
Right.
those are things that are in our
It
responsibility.
matters. It matters.
And, that's not something that has been, that wasn't where I grew up. So that's not been my vantage point. So learning from my peers on doing that. So that's exciting. I like doing that. I like getting involved. I'm just starting in the last couple of years to, with ACHE. I'm on a board with MHA for the MSC. So getting involved at the statewide level is exciting because you get to hear, how is the rural health transformation program going to be rolling?
Mm,
What's going to be happening with that? So that's kind of exciting. I think if there was one that's
yeah,
exciting, that is
that's
one.
it.
Um, I mean, we're not excited yet because none of us have gotten any money, but
Right.
we're going to be excited. Um,
Yeah.
and so it all was well intentioned. So we'll see how it goes.
Yeah.
And so that I think that is an exciting time to see how rural health is going to transform using the new program.
Yeah.
And so I think but we are all working together with the help of MHA connecting us. And I think that we are in a really strong position in Missouri to do that. And so I'm super excited about that.
Yeah. Well, two follow-up questions there. So, please tell me you've referenced MHA throughout being on the course, being on the board, but throughout this conversation, especially as an independent system where uh, you just don't have the resources of a large system. So, one, how has MHA been able to supplement a lot of that for you, and for other leaders listening, how would you encourage them to reach out and engage? And then secondly, where are we at with rural health transformation? I know director was you're kind of talking about. I thought a director was supposed to be maybe presumed to take the helm at some point, and then the hub and spoke model would come about, and selection of who was going to lead each region. What do you know? What's the latest?
I'm not John Doolittle, so I don't have the good goods. But
Okay.
I think let's go back to your first question, which
Yeah.
was, what did you say? Tell me.
Just with MHA, I mean, in terms of
Oh, how do they support us? Um,
yeah.
you know, when you work in a system or even a bigger, like even the academic center I worked for, we weren't involved that much in MHA, which I think is a missed opportunity. It's a missed opportunity for connection and networking with everybody. That's what I think. But they prioritize. So when you're in a for-profit corporate system, you have all these meetings and things at the corporate headquarters. Like there's a lot of mandates and education and requirements. And so I think it's hard. But when you're in a place like I am, you depend on MHA
Yeah.
to, um, and they've done a great job. I mean, John Doolittle has done an amazing job. He has assembled a amazing team that is so helpful to me. And even though I've been CEO 10 years, I still feel new.
Yeah.
Um, I was new and then COVID hit, and now I'm after
New
COVID.
again.
So I feel experienced but new again.
Yeah.
And so, they connect us with navigating those things. Like during COVID, they made sure. So forget that they do education all the time. Like the CMS COP updates conference just came up, and they give us education coupons so we can go to those things. Those are invaluable. They're wonderful, wonderful educational events, and we always use all of our coupons to do that. So I encourage any hospital to take advantage of that education because it is reasonable in cost and it's really good content. Um, the the conferences, all of those things. Like I think those are all really great managed things. But I think managing just some of these things like COVID, I think COVID's a perfect example because you know, we were all trying to figure out, who's going to get the vaccines and who's going to,
Mm.
and the state is doing it, but MHA kind of helps be a
The
connector.
leads. Yeah.
They help us translate how it's going to go, and they help make sure that we're in the right places. And hey, don't get left behind. Don't forget, because we get busy doing our day jobs, and so
Right.
sometimes it is such a helpful advocate for a hospital CEO. I just think that it's so important, and and I continue to feel that way every time I get involved with something that they're doing. So they're always trying to support. I think their challenge is, they have to support all of us. And so how do you support the systems? Because they represent them too, and the independence and the critical access and so but I think they do a great job of that. And I think that they have a good diverse team of people that are just so well versed, honestly. And the first time I had a big quality issue with, I had like this questionable finding in one of my surveys, my state surveys with one of the time critical diagnosis. And I was on fire.
Ah,
You don't mess with my time critical diagnosis. But they were so helpful to me. Like I called the quality representative, and then they have a legal expert there. And so they really helped me navigate that and make sure I was interpreting it correctly, and helped coordinate me and talk with the accrediting agency at the state. And so they just are such great connectors with the state.
yeah,
And that's important to those of us that are, you know, depending on, you know, our payer sources and all those things, and
right.
all the changes with 340B. That's another perfect example. They
Yep.
really helped us navigate the bills surrounding 340B and
Yep.
defending that and the lobbying. I mean, it's just invaluable. Like I
Yeah.
didn't always understand. I think I underestimated the strength and importance of like donating to Health Pack, but
Mm.
that helps me. Like the more they can lobby, the better we can run the
Well,
hospital, because it just, and, getting on the legislative calls twice a month and listening to them talk about all the legislation that they're out there listening to and keeping us updated on. So it's,
yeah.
it's like our own little system, to be honest. They keep us all connected for a Missouri system. And that feels good, I think.
Yeah. Well, I just was having a conversation with somebody else who had a similar revelation, with Rob Moncess, the entire team there, what goes into Health Pack, and even that the fight with 340B, right? I mean, the lobbying efforts, it's hard not to it's hard not to identify that it does come down to money, right? It does come
Yeah.
down to money, and when you're competing against big pharma, especially in that standpoint, right? I mean, it takes all the support. So, you know, I hope other leaders can take away from that you really do have to lean in and be engaged in that regard. But
Well, you get more economies and strength in numbers, and I think that's what MHA helps, particularly independent hospitals do.
yeah. All right, so we're gonna wrap this up. This has been fantastic. I can't believe you would have told me you feel like a novice because your enthusiasm is palpable. I feel like so is your expertise. I mean, but tell the guests. I mean, so what's as we leave part from here, what's one mindset shift that you believe rural healthcare leadership needs right now, and then giving them something actionable. I mean, what's something they can do or take away this month uh, to realize that change?
Well, I think that one thing, and I learned this a few years ago from, or I heard this and really embraced it from another CEO, a real experienced CEO. But I think when you're in an independent, a rural hospital situation, like we have to be connected and we have to have partners and we have to have strategic partners, but you can get too partnered, you know. Um, so you don't want to be too dependent on everybody because it will take away your agility, and honestly, it costs money. And
Yeah.
so we honestly do live by the mantra, and we try as hard as we can. We have for like the last 5 years. Do what you can do yourself. So don't outsource it. So we've brought in-house hospitalists, ER doctors, anesthesia, because they get aligned with us better. So we strongly believe that you have better alignment if you do it yourself. There are certain times you're going to have to outsource things, but try really hard to outsource to somebody that you know the owner of the company.
Uh, yeah.
That's real. I mean, I try. That's like a real rule of
Yeah.
mine. Because in our experience, when we've had relationships with big, national companies that we did not feel like we had good relationships with the top leadership, we didn't have much leverage. We
Yeah.
didn't have much voice, and they weren't really thinking about keeping us viable and thriving. And so I think if that was the one thing to kind of, because like I said, we may not all end up independent in the end, but we do want to try and keep our independence through whatever kind of
Yeah.
partnership comes. And so I think so one actionable item I think would just be, assessing that. Is your alignment right with all your partners? Are there better partners out there that are less expensive, that have more autonomy? Sometimes we get comfortable with what we have, we've used that company forever, but do the due diligence to look for other ones because and it's hard. I just made a really hard decision to change away from a telehealth partner that I had had since the beginning of
Wow.
COVID. And, it's the whole thing. He's a personal friend. Oh, he's my
Yep.
doctor. It's all the things. Like we are in tight, but it was the right thing to do for the organization to look to make sure we're getting the right service and price. And so we did make the hard decision. And sometimes it can start some renegotiation with your current partner, but most times it just helps you make sure that you're getting the right partnership. And sometimes
Right.
those partnership needs change, and you can't be afraid to change those partnerships.
Yeah. We talk about that all the time in our business. We could have a whole session about payers, the bukas, so to speak, right, and how partnerships necessary in a lot of regards, right? I mean, they're there, and they're good partners, right? But to your point, knowing the CEO of the company you're working with, the TPA, the PBM, the case management company, I mean, it just does. It just makes a
It
difference,
just
and
does.
it just does. So I appreciate your insights, and I'm sure that'll be a valuable takeaway. Dorinda, thank you so much for coming on. This was ever since I brought this up to you. What was that? A year and a half ago? I think you were one of the first execs that I said, "Hey, I'm going to do this podcast," and so this is kind of a full circle moment. So I appreciate you coming on, and thanks again.
No, thank you for thinking of me. This was really fun.